Welcome everyone to the MIT Social Entrepreneurship Alumni Group Zoom event, The Impact of COVID-19 on the Social Determinants of Health and Education. I'm Lily Fierro, VP of Engagement for MIT SEAG, and I'll be moderating today's conversation with Juan Diaz, our VP of Communication. And I'm pleased to have as our guest today, Dr. Lisa Egbonu-Davis, a physician executive with expertise in pharmaceuticals, diagnostics, and public health, and who is also the vice president of MIT SEAG. And today's event is an interactive conversation with Lisa, and I'll begin with a set of questions, then we will take questions from the audience. Please use Zoom's Q&A function to enter your questions anytime during this session, and Juan and I will alternate posing the questions to Lisa on your behalf. And we'll try to get to as many of these questions as we can in this next hour. And before we get started, I'd like to say a few words about our alumni group. And we are organized under the MIT Alumni Association. Our mission is to bring together MIT alumni and like-minded people to co-create a better world through social entrepreneurship and impact investing. Terminology here is important. What do we mean here by social entrepreneurship? Any organization that is addressing unmet social needs or environmental problems through a market-driven approach. And impact investments are investments made with the intent to contribute measurable positive social or environmental impact. If any of you are not a SEAG member yet, I'd like to invite you to join us on our online community where we share resources and host member live pitch sessions, mentoring programs, networking events to connect our members, and webinars just like this one. And to join, please go to mit-seag.mn.co, and we'll copy that in the chat for you to easily access. And at this point, I'd like to introduce Lisa. And to begin, could you talk about your career journey from practicing physician and public health practitioner to where you are today?
Yes, so after I graduated from MIT, I went to Hopkins for medical school and public health school with the intention of being able to run big public health programs and document program need and impact. So I trained in pediatrics in Philadelphia, and started early out in public health, expanding Medicaid in New Jersey, and also then running a handicapped children's program, third-party payer in Ohio, before getting married, moving to Indiana, where I joined the pharmaceutical industry and spent most of the next 20 plus years in the pharmaceutical industry, conducting and leading clinical and health economic research groups, and also doing a significant number of public-private partnerships to promote the health of populations, including infant mortality reduction, quality of care for the vulnerable elderly. Then took some time out in the middle of my career when my child was in high school, taught actually health disparities at Spelman, courtesy of Pfizer, and then worked as a healthcare consultant for Booz Allen, as an executive advisor after healthcare reform, and short stint as a self-funded entrepreneur for public health focused medical devices with some colleagues. And then after kind of running out of time and money with that, returned to pharma to focus on patient adherence and outcomes. And then have now moved into most recently diagnostics, focusing on strategies for innovating diagnostics that are going to have impact on clinical utility. And it's been very interesting to be in this role during the COVID pandemic. So that's a version of my story.
We're excited, so excited to have you because of the wide, diverse perspectives that you offer in terms of understanding health disparities and the social determinants of health from just a variety of approaches and industries. And so as a practicing physician and public health leader, how did these social determinants impact your work?
Well, it's very interesting because it started in medical school. I was doing a work study research project with my faculty mentor who was in the School of Public Health. And she was serving as the expert advisor to the Baltimore City schools. And she was an expert health advisor, and she needed to gather data on the relationship between socioeconomic status and child health. So I conducted a literature review for her to support her expert testimony and documented and published actually in a premier journal on the relationship between child health status and socioeconomic status, including things like severity and prevalence of asthma, hearing and vision disorders, lead poisoning, abuse, all those kind of things. So it kind of started very early, my understanding of the relationship between social economic status and other components and health status. And then, of course, as a resident in West Philadelphia, which was a pretty underserved area, I get to see firsthand the impact of poor housing and crowding on asthma, on family dynamics and stress, low birth weight, prematurity, all of those kind of things, saw it directly. And then as a public health practitioner running programs for children who were eligible for Medicaid or eligible for disability services, it was clear that the context of their home, their house, their family's ability to eat, secure services, both health and educational, really impacted the students.
And how did that experience transition over to your work as a healthcare research and industry leader? And then how do the social determinants now influence what you're currently doing?
So when I started out as a clinical research physician at Eli Lilly, they were in the middle of a lot of community focus because they at the time had the highest Black infant mortality rate in the country in cities over a certain size. And the first thing that the community leaders were doing was questioning the data and challenging the Children's Defense Fund. And so part of what happened was because Lilly is a leader in health in the community and the major employer, it wanted to deal with that problem. So in addition to my role as a clinical research physician in infectious disease, they looked at me and said, okay, given your background, help us with this problem. So I helped to design a public-private partnership collaboration between state and local health departments, Lilly Endowment, the foundation, and Lilly, the company, that developed a kind of 4-year plan for attacking infant mortality in Indianapolis. So pretty much out of the bat. And a lot of it was related to things like transportation. One of the biggest issues was lack of access to prenatal care, which was a result of a spoken wheel bus system. So you would have to travel often 2 hours after you drank your 40 ounces of fluid to get your ultrasound while you were pregnant. Clearly, people didn't do that. And in fact, one of the biggest hits of that intervention was a mobile ultrasound van that went to the community and delivered ultrasound services. So pretty early on, I got to do both of those things. And that kind of theme has intertwined because pharmaceuticals in general are a broad-based intervention for a variety of populations, and access can be an issue. And I was focused on the value of our products. So in addition to showing how our products could work and impact health, we also had to provide support for access, whether that was reimbursement assistance or other methods. And we also often provided educational tools to support health literacy and public health to support adherence and outcomes. So pretty much all along the way, those things have been intertwined. And then last, I would say in my current role in diagnostics, we have the COVID epidemic. And we'll talk some more about that later. So
yeah, I think that's actually a perfect transition to touch on it now, because you've talked about this really broad-based and multifaceted approach to a health intervention. And how have you seen these approaches change, or the need for these multi-layered approaches that exist at a variety levels of access, whether that's financial, even physical, or transportation access? And how has that altered during the pandemic?
Well, the pandemic has kind of worsened every single aspect of social determinants of health and education. So if you start from the top, economic stability, massive disruption because of stay-at-home orders, job loss of wages, loss of income. So globally and in the US, and the most vulnerable populations who were already tenuous in terms of savings were the hardest hit. those essential workers. Number two, in terms of actual physical environment and safety, those essential workers were threatened by the existence of their jobs, right? So they had to go to work. They couldn't work from home. Bus drivers, direct healthcare providers, often even including the techs or the people who clean the hospitals, who were those providers or grocery store clerks were exposed and often not protected early on in the epidemic. So they had very high rates of infection. Then in terms of education, I think the estimate is over a billion children's education has been disrupted as a result of the epidemic. Schools have been shut, US and elsewhere, and often the adolescent children of families who are in distress have had to go become the breadwinner to support their families, disrupting both their health, their education, as well as exposing them to the virus, even though in general they've been less sensitive to it. As a result of all of that, and supply chain disruptions, food insecurity has gone through the roof. And so that's one of the other major social determinants of health. Socially, in terms of communities, this has been disruptive because of the economic impact, people isolated from each other, extreme increase in rates of mental health, anxiety, depression, domestic violence, and isolation from people being stuck at home. And again, that's disproportionately affected families that don't have additional resources and are in crowded conditions, which makes everything worse, both in terms of health and social interactions. And then the healthcare system itself, which is the last social determinant of health, access has really been disrupted because of overwhelming case counts, sickness from providers, and then drops in healthcare coverage. So it's been a perfect storm of increasing existing disparities.
Yeah, and you touched on education being a social determinant of health, but also the other social determinants of health are the same determinants for education too. Could you talk about the complexity of this interaction and all of the challenges that this interactivity between needs for health and education, what that raises?
Yes. So on the one hand, it increases complexity in the sense that it's a circle. Education and educational attainment is one of the best predictors of longevity, morbidity, mortality, et cetera. So that is part of the circle. On the other hand, poor health, as I learned early on from my study in medical school, is associated with poorer educational attainment as well. So children who have hearing difficulties, children who have vision difficulties, children who have chronic conditions that interfere with their attention span, whether that's difficulty breathing with asthma or attention deficit disorder, untreated, those children are less likely to go to school, remain in school, achieve in school, finish, get good levels of numeracy and literacy, finish high school and attain college. So it is very much a circle, but the same underlying issues of economic insecurity, homelessness, chronic hunger, food insecurity, dangerous and threatening physical environments, and traumatic social environments, those also disrupt educational attainment. So on the one hand, you can say it's complex in the circle. On the other hand, you could say it's simple. If people don't have food and they don't have jobs and they don't have housing, and their community and social context is threatened, then that's going to impact both health and education. So it's an argument, in fact, for addressing some of the underlying systemic causes on the way to trying to address disparities of both. And I will add one major social component, which I didn't touch on, which is the whole issue in the United States in particular of racism, what has been exposed in this pandemic. As Dr. Fauci said, this is really, COVID has really revealed the undeniable effect of racism in the United States, with its chronic association with discrimination in housing, employment, social capital, et cetera. It really has, and disproportionate burden in terms of economic insecurity and food insecurity, which has been associated with long-term stress and chronic conditions. So it's a whole bad circle of increased exposure because of poor quality jobs, poor quality environment, and as well as underlying chronic conditions, which are by and large socially and not genetically determined. So.
It's interesting how, exactly like you said, it's complex and yet very simple, but still, even though the factors I think are very well articulated, how to try to address them ends up demanding a variety of layers of interaction, which you described really well in terms of the work that you did at Eli Lilly. Could you talk a little bit more about these kind of mixed tech and also mixed like modality and interaction solutions that are really demanded by these kind of hard challenges in health and education?
Yeah, and some of them are, it's very funny because as I started going through this, I was thinking, well, this sounds a lot like the Millennial Development Goals. So on the one hand, it sounds different, but on the other hand, it's the same. So it's the same thing that many social entrepreneurs have been trying to address with combinations of tech and non-tech solutions. So starting from the top, I think that if we look at opportunities for employment and economic stability, people have used technology for job creation for the poorest of the poor, from the Grameen Bank model, right, which has been around for a long time, to things like the Markle Foundation is trying to increase the openness of employers to re-employ large numbers of massively displaced people, some of whom are skilled, some of whom have less skills in the United States. And there's a lot of need for technology to support that, because there's technology platforms that support access to employment opportunities and underserved opportunities. So there's a large number of platforms that do that focus on different different communities that range from previously incarcerated people, Black people, Latinx people, women, moms returning from, and which is a big issue for this pandemic has disrupted women at work massively because of the need to return to home, and the burden of childcare has fallen on them with the schools closed. So that's a kind of basic tech solution, which is support a marketplace and encourage it, and it can get funded by the employers. And there's a lot of examples of that. So that's one kind of example of using tech to help drive the economic security front. And there's a lot of other ones. On the educational front, there's combinations as well. So you have all these organizations that range from STEM enrichment and connecting girls who code, et cetera, and trying to reach into communities to provide supplemental education. And some of them are very tech. Some other ones are less tech dependent. So I think some of the biggest and most effective, I'll talk about a little bit more, have relied less on tech. Things like Reach Out and Read, which is a massive program that is based in pediatricians' offices, right? So it's not quite a market-based solution, but it's a massive solution that was started by social entrepreneurs who were pediatricians in 1989, who noticed and knew the literature that children who are exposed to books in the home for their 6 months are more likely to succeed in school early on and later on. And so there is now a pediatrician office-based program that provides books as well as parental education that's recommended by your pediatrician to parents, and it shares with parents how to read to their children. And it's kind of a basic provider-led and recommended not that high tech intervention other than maybe the book supply. It puts it together that has been massively affected, studied with research tools and documented impact on children's learning and achievement. So that's a kind of example on the other end with a very little bit of tech, whatever, but it kind of addresses one core component. And I think that's part of the theme, which is the problem is really big and you can get overwhelmed and just say, okay, well, the answer is only like a change in government or whatever. Maybe, but on the other hand, there are components of the problem and where there's some potential intersection between sectors to address a significant component of a problem and have impact. So and my other example of that would be, there is a program called Revolution Foods, right? And what they do is they're social entrepreneurs. They're located in California, but they're now spread out throughout the country, and they feed 2 million school children a day using locally grown food, a very sophisticated supply chain management to lower their costs, and they deliver and they compete with other vendors for school-based lunch programs funded by the government. They're a for-profit entity, and they deliver food, and they win a lot of times the contracts, and they've been expanding with the COVID. Oh, and with COVID, they had to pivot because they couldn't deliver the food to schools, so they had to deliver the food to other settings. So they are using technology in terms of their supply chain and a pretty savvy model for low cost, but they're having that kind of massive impact on the food spectrum. So those are a couple of different examples of technology versus not.
Thank you for those examples. It showed, all of them show a really fascinating intersection of government, community, and business. And I think that is a fascinating intersection that invites a lot of great impact overall. And given this interesting problem and solution space in health and education, which kind of pieces and what challenges do you see are the ones that could best benefit from innovation and social entrepreneurship right now?
I think there's a desperate need for support for the employment marketplace. And I don't care which piece you pick, whether it's a training and reskilling piece that you can leverage technology to get to people and connect them to the skills they need, whether it's employment marketplaces to help facilitate the interaction between people who are trying to hire and people who are seeking work. I think that's one of the massive areas, because without economic security, there's just this unending sea of need. So I think that's one of the big areas of opportunity. I also think that technology can play a role and needs to step out in attacking racism. Technology has actually been accused of reinforcing patterns of behavior that are bad. So some of the AI-based technology for hiring software, which was supposed to take bias out and which is generally funded by employers, has been accused of and has sometimes been putting bias in. So I think there's an opportunity to have better, smarter technology to foster skill-based hiring. The Markle Foundation, for example, has a toolkit, but when you look at its toolkit, well, it's in need of tools. It has some tools, it has a marketplace, some of the marketplace tools, but then it kind of has a checklist for hiring. I'm like, really? And so I think there's an opportunity to develop some better tools for skill-based hiring that don't rely solely on credentials, and work with employers that are trying to expand their employee base and employees who are people who are seeking work to do that. So that's an area. Another area that I think we talked about, the education area. There is a Marshall Plan. There are billions of dollars pouring into the school systems right now to fix a year out of school. And school systems are important, but they're notoriously rigid. The opportunity is for social entrepreneurs that are more flexible to figure out ways to partner with those school systems that are getting increased funding in a more flexible way. So classically, that has involved after-school supplemental programs to augment things. And STEM is a desperate need area. Yes, you have Khan Academy and there's lots of content, but there's a need for content plus an interactive mechanism that joins people to a community. And so I'm not sure exactly the business model, but that's what you guys but I do know that a massive amount of money is pouring in there into a rigid system, and they could use some help. And so the opportunity to create some interesting prototype models in that context, collaborate with some of these systems and potentially scale, I think is a particularly interesting area. And then of course, I can't leave without talking about health. Health is, of course, there is an organization called Health Tech for Medicaid that has been focusing on using technology for what's clearly generally a lower resource population, but it has an income stream from the government for supporting services. So those are the two things. So even if you develop something for Medicaid, you get some of an income stream, and it's a pretty big one you can get access to, and you can leverage it for uninsured and Medicaid and others. And I think there's a lot of opportunity to support people and behavior change. So that's another area I would definitely look into in terms of health, supporting behavior change, supporting access, supporting lower skilled workers with both training and credentialing, like community health workers, as well as providing technology that links them either to providers or to intelligent protocols to help support behavior, because people with lower skills often are the best at helping communities address the social components of where can I go walk, how can I get good food in my neighborhood, and if we connect them to the bigger systems that are getting these income streams to actually address health and the social components of health, I think that's another area.
Amazing. Thank you for all of your perspectives on these many different areas that are definitely critical and unmet right now. Do you have you listed a couple really awesome ones just now. Do you have other specific case study or whether it is a company or a research group that you feel has a innovative approach that is very promising for impact in terms of tackling economic access, STEM education, and healthcare education and training in an innovative way?
Yeah, so one of the examples I think that I'd like to highlight is called Wealth. It's actually a very technology-based application, and it's called WELLTH. It's one of these companies that is in that health tech for Medicaid space, but is not solely in the health tech for Medicaid space. It has clients in the employer sector and other more resourced insurance sectors. And what it is it is a technology-based app that helps people adhere to their medication using behavioral economic techniques. So what it does, because even though people want to take their medicine, it's hard to remember, or sometimes they just want to forget that they actually need medicine. I've kind of studied this, a lot of reasons. But what they do is when someone's enrolled in the app and they have the medication, for example, you start out with $30 per month. And you take pictures of when you're on your smartphone. And if you don't have one, this program saves enough money that lots of the providers will give you one. And of you taking your medication, because they started with really high risk populations that were costing a lot, including people who were on Medicaid and Medicare. And you take pictures and you get rewarded by not losing $2 when you don't, you lose $2 if you don't if you take your picture and show that you're taking your medicine. And that's behavioral economics principles, which is people are more responsive to losses than they are to gains. So if you did it in reverse, it wouldn't work as well. If you said, oh, you get $2 if you take your picture, it works better if you lose $2 when you don't take your picture. That reinforces behavior. And then you accumulate these credits towards their special credit card over several months. And then you can use that credit card for reasonable things. So you can't use their credit card to buy cigarettes or alcohol or whatever, but you can use it to pay for food, to pay for telephone, to use other things. And that program has been incredibly successful in demonstrating like 80 to 90% adherence rates, which is unbelievable because normal adherence rates are under 50% for a year long, and large reductions in emergency room visits and costs. So they've been doing that with medication adherence. They've been doing that with changes in diet and behavior. They're working on it for mental health, and they've worked with Medicare and Medicaid populations. So it's been effective in poorer populations. And they also work with privately insured plans and employer plans. And so that's a for-profit company. They're expanding their base, but they're also having a major impact on health. So that's, I think, a very promising kind of company approach.
And, you know, this is another interesting example of this need for collaboration between, in the case of wealth, it's like insurers, but and also government and technology and private business. And that could possibly make impact measurement kind of challenging. How does impact and the quantification of impact happen? And how is it defined whenever you're working on a venture that is trying to tackle one of the social determinants of health or education?
So I think, as I was saying, in order to have impact, you have, even though the problem is big, you have to focus your target for impact and then maybe scale. So the examples I've listed, so for Reach Out and Read, their impact is measurement comparing users to non-users, those happened to those children when they went to school, and subsequent outcomes with them. So they can compare that. That's not a randomized clinical trial, but it's a pretty large scale trial, and they've been studying it more than 20 years. So they've got some pretty good data on their impact. For these employer apps, I think it's more of a challenge, but it's gonna have to be, okay, how many people and what types of people got employed? How many employers work with you if you've got an employer-based directed platform to try to increase access for people with a variety of different disabilities or minority communities, and how many people got employed as a result. Those are going to be the measures. For some of the health apps, again, it depends. Wealth is collecting data on prescription drug adherence, and since they're working with insurers, they've got data on healthcare utilization among participants versus not, and duration of participants. If they're really good, they'll do some randomized trials of people who get the app versus not. But frankly, if your pre-post data is strong enough, which is for insurers, and they haven't cherry-picked the participants, they'll take that. And their data is pretty strong in terms of the magnitude of change in costs. So it is very much going to depend on the intervention, the measure of impact.
And for I guess these interventions that do require a layer that happens at, for example, a transportation layer or an broad education layer. How do you kind of factor all of that in as you're measuring the success of each of these layers of the intervention?
Well, I think you do it in context, right? Because usually you're going to start in a local context, and that's, I know, something that people know from social entrepreneurship in general. If you're going to be successful, you're more likely to be successful if you really understand the problem really well and involve the users in the development of the intervention. So I think in terms of a layer, if you know you're in, the San Francisco public school system for food, okay, then you should know what's happening in that system for transportation, right? And you can know what you can or can't address it. In this case, when schools were out, they had to find a different way around the system. So that's it. Sometimes the interventions directly attack the layer. So for example, COVID vaccine uptake. Well, people are collaborating with Uber and Lyft to deliberately provide access to the service. So sometimes that the intervention is addressing that layer. But in any case, when you design the intervention, it's got to be in the context of these are the barriers, what's possible to overcome or change or not in this context, and therefore, what can we solve or not?
Yeah, that makes a ton of sense. At this point, I'd love to open up to any questions from the audience. Do we have any questions at the moment? Okay. And I'd also love to invite Juan to jump in and ask Juan if he has any questions for Lisa.
Yeah, hi, Lisa. Yeah, that was wonderful. It's a lot of information, really good information. So thank you. I'm more curious, I think, to hear about, just hear a little bit about where we are. Like, you read a lot of the reports that we've fallen back, right? I think you mentioned that there's a lot of money pouring into helping schools and children catch up. And well, let's just stick with the schools. Are there, and now given, do you think there will be, or how did you see any more technology focused changes in the near future, given that a lot of the schools are now going to be online and going to have a lot of more online presence as opposed to in-person presence? I guess, how do you see that impacting maybe any possible interventions in the future?
To the extent that online access was improved during the pandemic, or has been improved, I think it opens the opportunity for more of the online programming that includes a lot of tutoring and enrichment exists to participate and try to get access to and support more of the children who need it, even if that's through a mixed model of we charge the people who can afford it because we're going to have this designer service that's really good if people want it, and we subsidize the people who can't. So I think it offers an opportunity to take some of the information, right, and the content that's there. Content is largely there. What's missing, though, I mean, Khan is there. There's all kinds of content. What's missing there, though, is the interaction support, right? So, because some children can do this on their own because they just have exposure to content, but many need a group, a peer group, a cheerleader, a parent supporter. And I think the technology to support that is really needed, right? And to the extent that the systems are more open to that enrichment and external support, that I think is an opportunity for vendors who are ready to do it. I mean, Wiley Publishers is jumping up and down. I know some entrepreneurs who do training for teachers. So those are there are ongoing private enterprises. I know because I'm on the Hopkins board of advisory board for the School of Education. And so those entities have an opportunity potentially to scale, to do more teacher training, to help the teachers be more effective online, right? Because that's one of the missing links, is that the teachers aren't necessarily comfortable with it. So there's content and community creation for the students. There's opportunity to provide more educational support for the teachers so that they feel more comfortable and are more effective online. I think there's combinations of that. It's on, again, a lot of the content is there, but it's not coordinated. It doesn't seem to be well curated. And it's a challenge to get to.
Yeah, that makes sense. And I'm curious, I think we have some more questions coming up, but I just want to follow that real quick. Let's say for a budding social entrepreneur, do you recommend that they, are there any resources that you recommend or any source of funding? And aside that, I was also curious, are there places where you recommend that they start, right? Is it like, sure, they start with like their local schools and figuring out what they can build and what their local problems have, and go from there, or try to plug into like larger, bigger, just programs?
Yeah, I would recommend you start where you are passionate and have some familiarity and can gain more, right? Because what seems to be the most effective approach is to dig in and with a focus, with a target that's amenable, has a little bit of money, and is willing to flex, right? And then build that model, and then with the plan that, yes, your vision is you'd like it to be a scalable model, but you build it, you test it, you figure out what works, what doesn't work so well, and then scale it. And I think thinking about where in the ecosystem you want to play and how your niche is going to be supported or potentially could expand as you're deciding what your model is key. Because when I look at the ones, when I read them that were scalable, they tended to be ones that had figured that out from the beginning. We're going to get our funding ultimately from the school-based lunch program or the school-based summer programs, right? That's a source of funding. Or, some of the food entrepreneurs, one of them is getting money from that taxable donation from the convention centers and other large food vendors. It's called Gooder in Atlanta. And she started out, she was like giving out food in food kitchens. I said, well, that's never going to scale. So then she used blockchain to match wasted food with food acceptors, pantries. And so she built it in Atlanta, which is where she lives, and evidently she knows the players, whatever. And then she got lots of publicity, and now she's in like 6 cities, right? But she started out with the plan that, okay, I'm going to do a scalable something. Somebody's going to be my continued source of money. I'm going to have a little bit of next, and she actually used technology. I thought that was pretty impressive. And now it's scaling. So I think that model can be really effective.
Perfect. Thank you. Yeah, that was a great. Thank you. And I'm gonna now read some of the questions that people have posted. This one's from Daniel Ross, and I think it segues quite perfectly. It says, I work in healthy food access and diet-related disease. What do you see as most promising interventions?
Well, one of the things I did say is promising, but I couldn't find a model that was economically self-sustaining, is community gardens. So I just may be missing it. I tried, because I'm like, okay, we have all these people giving the food, but like, can somebody grow the food? And so I'm not sure how sustainable that is economically as a model, or that has to be a non-profit, whatever, continually funded model. But I think that was one of because it provides direct food. It gives people exposure to food. Kids, it's actually easier to train kids. I'm a pediatrician by training, to eat in a certain fashion, and then they stick in it, than to change adult habits, which are important but harder, and possible. But and it's possible to do, but it takes more effort. And so that's one of the ones that I really see. But the other thing is these apps that talk about reinforcement, right? In terms of, so this wealth app, which is insurer based and has the economics incentive, which are fairly small but very impactful. The peer models also work, right? Their economics vary, right? It's everything from Weight Watchers online to to peer group support for diet and physical exercise change. Psychologically, that works. The issue then becomes, okay, what's the business model that you're going to work through? Are you going to be member supported? Challenging. Government supported? Possible. Insurer supported? Also possible. And interestingly enough, that entrepreneur that I said had the blockchain and the wasted food connected to where the food, her latest announcement is she's aligning with one of the health plans, right? Because now the health plans are incented to deal with social determinants, including food. Food is one of the biggest, and exercise, one of the biggest drivers of everything. High blood pressure, cancer, obesity, heart disease, and all that stuff costs money. So if you have an incentive to to pay for a population over time as a plan or a payer, then you have an incentive to try to help that population change its behavior. And so they're a potential ally in some of the efforts.
And we have another question with Daniel Ross replied just to continue that conversation. They said garden prescriptions for health player marketing and benefits.
Maybe. I would try. Payers are tough. I know because I sold prescription drugs and diagnostics to them. So yes, maybe. But you have to go test that with some of your local payers and see how that would work, including maybe your some of your federally qualified health centers who are very public health minded. They don't have a lot of money, but they are very public health minded, and you might have an opportunity to really develop good prototypes with them.
And we have another question, and Nithi Vivatrat, and apologies if I mispronounced the name, asked, do you see changes in the market to better align our healthcare payment model to better address SDOH?
Social determinants of health. And the answer is yes, because the answer is the incentives. If the payer is responsible for a population for a sustained period of time, then their incentive to actually address the underlying issues. The problem with the existing payment system is that most privately insured people in the United States change plans, employer-based, every 2 to 3 years. So there is, not only is not prevention period isn't all that incentivized, because they don't get the benefit of somebody taking their diabetes. Well, diabetes may be short-term. They don't get the short-term benefit, the benefit, but they get the short-term cost. Most prevention takes several years to return. And if you only keep the person for 3 years, there are fewer incentives to return unless you're also getting rewarded for quality, which they do, right? Metrics, how many of your people have controlled hypertension? That's part of why they put those quality metrics in there, because the financial incentives weren't really aligned. But that's changing. There is more pay for performance. There is more flexibility coming into, if you've seen the recent stuff out of the feds, the CMS in the US, the big public payer, to allow people to pay for things like social work, like smoking cessation. They've been more flexible about the kinds of services they're willing to pay for, so that you can start to deal with those social determinants, right? And if you have more flexibility to pay for social worker, then they can work on the housing problem, which often is the real problem with a kid with asthma, right? Or homelessness. So yes, those incentives have started to increase. And the more we go towards payers who are responsible for populations for long periods of time, the more flexibility they get to take the dollar they get in on those determinants. Because if you compare us in Europe, for example, if you add health and social costs together, what I read, at least in one article, was that we pay similar amounts. I don't know if I believe that, but ours is skewed to paying for health, sick care versus social needs, which would have prevented the need for some of the sick care.
Well, thank you. And I don't think there are any other open questions from the audience at this moment, but if you have any questions, definitely feel free to submit them. So then, yeah, following that on the, I want to go back on the garden prescriptions, and
people have given prescriptions for food. There are programs where people are giving prescriptions for food, and to the extent that somebody is allowing those to be filled, whether that's through your health system or some other program, that's very effective. I mean,
yeah,
children don't learn well. Hungry people eat badly because they eat cheap food that fills them up. I mean, and it's not a good thing.
yeah. I just brought to mind, I live in the Washington, D.C. area, and one of my housemates a while back used to drive a converted school bus, like a mobile farmers market, essentially, to food deserts and food swamps. But I believe that was a nonprofit though, not a social entrepreneurship. So that reminded me of that example.
Yeah. But the health plans may be a source of funding if you've got a good model going with some high flow for food.
Yeah. And now I'm somebody, and Daniel Ross also replied, have been working with payers on produce prescriptions with good health outcomes, but still largely grant funded, still building evidence base for reduced healthcare costs. So
yeah, payers aren't like evidence, right? So they're used to like evidence that we produce for drugs or evidence that we produce for diagnostics. So they're show me people. They're like, okay, this sounds good. Now, let's do this pilot project in my population, and then you show me the impact. So that happens even, I don't care whether you're a social entrepreneur or not, payers do demand that level of evidence usually before they become consistent customers for programs. That's not atypical.
And is that I guess like a constant or a usual challenge for people trying to start social entrepreneur businesses, just trying to get that much? Do they require a lot of data, or a lot, like, is it unsurmountable, or are they pretty easy to work with?
It depends on who your stakeholders are, what level of evidence they require, and what your intervention is, right? In education and health systems, they're big systems, they're largely publicly funded, some privately funded, they're a huge percentage of the economy, and they tend to want more data over time. They'll tolerate a certain, preliminary evidence and pilots, and they'll pay partially for preliminary evidence and pilots, depending. But then if you want to be scaled in, 20 schools or 3 school districts, that, they're going to want to see, okay, how did it work? And it doesn't necessarily have to be a randomized controlled trial, but it can be good evidence that the people who had more of your intervention had more of the impact, and that it wasn't so selectively biased that it, you just basically pulled in the people who were going to respond anyway. So yes, evidence is required, but it's, the level of evidence really depends on your target for funding and also your scalability in your stage.
Yeah, and I guess I'm curious, is there a space for like a lot, like, let's say smaller, because when I think of working with a payer or working on healthcare, my mind just goes to large hospitals, large insurance companies, giant teams. And I'm just curious your thoughts on if there's space for, just smaller players, let's say somebody with, a much smaller team, and
smaller employers. And employers tend to be where people do their initial start. Employers tend to be the space that play to pilot things, because they have many of them, health conscious ones, have an employee base that they sustain for 7 or 8 years. So they want their employees to be healthy. They want that they are incurring their employer these costs. If they happen to be a concentrated local one, even better, right? Because then you can know them, they know your environment, you can set up small, pilot interventions and demonstrate impact.
Yeah, no, that makes perfect sense.
Well, even the big things start small. I mean, I had a conversation with Walmart because they have this program for entry-level workers, and I wanted to know what their model was. And what they told me is, okay, we started in Chicago. I think that's where the headquarters is. We started with like 20 people in a cohort group to try to show, could we develop people with high school diplomas or GEDs into pharmacy techs as a career track? And, they partnered with a local nonprofit and a community college. and they paid the people while they were going to school. And then they learned, oops, it didn't work unless they gave them social support services to deal with other stuff because they didn't graduate. And then they did another cohort. And then the next time they provided social support services, then everybody graduated and a bunch of people, stayed to work. And then now they're up to their fourth cohort. That's a huge company. I mean, they got plenty. And so now I said, so now, and they're like, well, I think, and I was like, did you publish it? No. I'm like, okay, that's not so good. You should just publish. It's okay that it's not, the New England Journal type interview. And then they say they're talking about expanding now. So I think realistic expectations about, you don't want to stay forever small, but the expectation that it's okay to start small with a plan and expand.
Yeah, thank you. That does make sense.
I think building off of that, like when you start small, I think this is always a challenge for many social entrepreneurs, especially within the health and education spaces. Even in order to establish those kind of initial partnerships, there still has to be proof of concept. And if there's a tech component, that always leads to a need for capital, right? Because there needs to be some resources. And the major players who may be interested in this in the long run aren't going to be working with these teams at the pre-pilot stage. So how have you seen entrepreneurs navigate this really early, super early stage challenge of how do you find capital and resources just to run your first proof of concept pilot?
You need some angels. The same way as for people. I mean, because I'm thinking about, I have a friend who runs this social entrepreneur. It's called Calm Clarity. It's a B Corp. And her vision is using meditation and mindfulness to support first generation college students, of which she was one. And, when she set up that entity, I mean, she was like, living in her parents' house, and then she had friends. She had friends from business schools. She had she had worked for a couple of years in finance. But the initial couple of years, it was kind of like her own equity and friends where she said, this is my vision. And, that's who helped support her. Now, she didn't have as much her tech component, I would argue. So I don't know how much more capital she needed, but that's really how she started. And then her other thing she did was kind of the bootstrapping of, she started selling those services to companies and employees with the intent of using the money to fund what she really wanted to do, which is the interventions in the high schools and the colleges for students who couldn't afford it. So that's the other strategy is, is there a for-profit bigger partner that you can build on or spin out of, or just leverage for cash while you're building your other thing up. And there are foundations who will there are foundations that focus at different stages. But I still think a lot of them want to see initial proof of concept. So I think the initial one may really be, it's kind of like the angels.
A separate person submitted questions, and so I just want to be able to read them fairly quickly. Have you ever supported foreign schools directly or assisted supporters in that area? And they also asked follow-up, I think, is there any specific problems or issues regarding cross-border support?
Well, I personally have not supported foreign students directly. I just haven't been involved in that. Repeat the second question, are there specific?
So, and then the second question was, is there just any specific problems or issues regarding cross-border supports?
There can be, and it depends on the issue. I mean, there are a lot of global foundations. There are a lot of foundations and efforts really actively promoting international work, and with that focus, I mean, things that range from MIT Solve, that does both US and global and supports, social entrepreneurship at a certain stage. Challenges can be, are there limits in certain exchange of ideas or technology, given the recent rise in kind of, nationalism and fear of transporting technology. That's, I think, sometimes, and resistance to crossing barriers. I think other challenges are just really making sure you have everybody has a deep understanding of the culture they're in or working in, because working cross-border when you don't, or without partners who do, often results in kind of misunderstanding the lack of effectiveness. But other than that, I think I see a lot of cross-border exchange, especially in this sector. And maybe we should be learning more from each other, because some of the things that I've seen that people are doing in countries where they have interrupted internet service or problems with power maybe could be imported to environments where in theory most of the population has that access, but a significant percentage of the population doesn't.
And maybe I think the very last question was, is there a different view, before I think we have to end here, is there a different view of equity and addressing disparities now? And how do you feel about the frame of social determinants of health?
I think that 30 years ago, there was a lot less understanding and appreciation. And, when you talk to pediatricians, some of them said, well, that's not my job. Like, my job is to fix the sick child in my office. And it was public health people who'd say, let's try to have fewer sick children coming to your office, right? And we're working on the lead poisoning and the housing and whatever. Now I think there's a lot more unanimity and understanding that social determinants are the major things driving health outcomes, and that it's hard to fix things that are broken, and it's easier to prevent things from being broken. And so that is much more accepted now. The fact that payers are even talking about it, measuring it, is massively different from 30 years ago. And I'm really happy that the education people are starting to talk about it, not in terms of, oh, therefore those children can't learn, but in terms of, okay, let's all hold hands in partnership with others to figure out how we address them so that the children can learn.
Awesome. I think that's the perfect question to close off this conversation. And we want to thank you so much, Lisa, for joining us for this. It was incredibly educational and valuable. And I want to, of course, thank you for your amazing work and for shedding light on really the so many different layers in which you have created solutions and also given a ton of thought and care and attention to making sure that better health and education outcomes happen. And you've been doing this for a long time.
Well, thank you, because we really need social entrepreneurs to really dig in and fix some of these problems. And so counting on you guys.
Thank you so much. And thank you to the audience for joining us today. And we wish you a good weekend. Thanks for joining this MIT Social Entrepreneur Alumni Group webinar. Take care.
Bye-bye.